Hello, thank you to everyone here in person in San Francisco, and thanks to everyone tuning in online for Devex Live's Prescription for Progress event. I'm Catherine Cheney, West Coast correspondent at Devex, and for those of you who weren't able to hear the talk here in San Francisco, we just heard from Pablo Holman, who's a hacker, inventor, futurist, about breakthrough innovations for global health. And what I'm really excited to talk about with our panelists here is how do we go from breakthrough innovations to follow-through innovations. So Prescription for Progress is talking about how do we take the potential of global health technology to really drive impact and scale that up. And I'm joined by leaders here who do just that. They work through partnerships, they work with health systems to bring technology to bear on some of these global health challenges. So just to my right is Ramesh Raskar. I'm going to quickly introduce our panelists and then we'll dive into the conversation. Ramesh has worked at the intersection of technology and health, most recently at Facebook, and now he's working with the government in India on some of their emerging technology and health opportunities. Next to him is Chuck Slaughter. He's the founder of Living Goods, which you all may know does really amazing work in health at the last mile. We'll hear a bit about that. He's also an advisor to the TPG Rise Fund here in the Bay Area, which many of you may be familiar with, and we'll hear about. Next to him is Nithya Ramanathan. She's the co-founder and CEO of Nextleaf Analytics, based in Los Angeles. They do work on data and the Internet of Things to basically ensure that these products are having the impact they're intended to have to the last mile. And then next to her is Dickie Settle. He works on digital health at Path in Seattle. And Dickie's going to share with us a really interesting partnership that Path has just signed with the WHO on digital health transformation. So I want to start with a question for all of you. And now the audience and our online audience has a sense of who you are. But can you tell us, in an event that's all about partnership, what is a way that you have used partnership specifically to bring technology to bear on your health priorities? And what are some of the challenges that you've had to work through in order to see impact? So we'll start with Ramesh.
Sure. I mean, as a professor at MIT, we do believe in breakthroughs, but follow-through can be challenging. And so what we have been doing is really working with ecosystem in Boston, but also, in my case, partners in India. And the way we have set it up is we actually teach courses at MIT that really focus on all kinds of breakthrough technologies and through venture classes. But we also have a partner in India, in this case, LV Prasad Eye Institute, which is in Hyderabad. And we have a center that's physically located inside the hospital. And we have millions of dollars of grant that come into that particular innovation center. And that's how we're able to bridge the gap between the breakthrough and the follow-through. And the challenge really there is to realize that when you work in context of some of these challenges, the initial results are very quick. The first 80% you can get very quick. But to really get the last 20%, it's the classic 80-20. And that has been a very new challenge. And I would just say that focusing on innovation and entrepreneurship, especially entrepreneurship, could be actually misplaced in many of these areas. And we should be focusing on co-creating as opposed to entrepreneurship.
That's a great takeaway, thank you. Chuck, what about you?
Well, first of all, thanks for having us here. It's delighted.
Thank you.
And yeah, so as many of you know, Living Goods supports community health workers in Africa. And over the last 10 years, we've demonstrated that a digitally empowered community health worker can really have a significant impact on reducing mortality. And our research has shown up to 25%. And the strength of that, we've scaled up quite a bit. We're serving almost 7 or 8 million people with 10,000 health workers. And so the big question is, now what? That is all what we call necessary but not sufficient. And it brings up sort of two big partnership challenges. One with governments, so we work with governments today, and the other is with funders. And one thing about technology is most of the massive disruptions of technology have not been perpetrated by large incumbent institutions, whether they were investors or companies. And so if you think about governments and aid funders, they're two of the biggest, sort of most calcified sets of institutions. So our challenge ahead is how do you bring them along the digital journey to realize the potential for this kind of disruption?
Absolutely, and I would say for those of you who work for some of the incumbent organizations,
Yeah.
that's part of what brings a lot of them here to Silicon Valley to try and figure out how to get kind of ahead of the curve. So thanks for that. Nithya.
So at NextLeaf, we build sensors and analytics platforms. We've been putting them in fridges to monitor vaccines, make sure they're stored at the right temperature. We've deployed about 15,000 of these sensors now, covering about half the clinics in India, and reached about 12 million babies a year in terms of protecting the vaccine supply for them. And the challenge for us is really kind of, I think has been really nicely touched on here, is once you build the technology, then what? And for us, we found out, it turned out the data actually helped align a bunch of different people's incentives in a really lovely way. And so it turned out that the data could be used to answer a bunch of questions, and you had to figure out who needs a question answered and how you help answer that, so that you can align everybody towards a measurable outcome. And so for us, the partnerships actually emerged really organically, because we started with nurses. We started answering their questions. When does a vaccine need help? You know, the fridge sends out an SMS now, and the nurse knows that they know when to go take action. But the data also answers questions at the Ministry of Health level. It turned out the data was answering key questions for manufacturers, fridge manufacturers, for WHO, for UNICEF, and everybody started finding value in this data. And so for us, the partnerships actually organically really emerged because we were answering everybody's questions, and we were focusing everybody on a really measurable outcome, which was keep fridges working and keep vaccines safe. And then the question just became, okay, how do you kind of then corral the resources that everybody knew was needed now to actually kind of take all the actions that they knew they needed to take?
Great. And Dickie, can you talk about, we know when it comes to digital health transformation, why is partnership essential to that? And specifically narrow in on challenges, why is it hard?
Okay. So about, 5 or 6 years ago now, a colleague who was working with UNICEF in Uganda did a survey of all of the digital investments that were being made in that country, and really was reviewing it, and in partnership with the Ministry of Health, trying to understand how donors and partners were investing in digital health. And what he found something on the order of 70, 75 different investments. And again, this is 5 or 6 years ago. And they were all small pilots that were taking place in this country. And they were poorly funded. They weren't well aligned or coordinated. They really hadn't been communicated to the Ministry of Health. They were shocked to hear that so many of these investments were being made in their country and weren't really going to lead to any lasting impact. And so it became really clear. First of all, the Ministry of Health declared a flat moratorium, no more of these pilots, right? It's the biggest public health disease in digital health, right? Pilotitis. And we need to really focus on ensuring that these are aligned and coordinated and leaving lasting impact and investment. And so while in Uganda, the ministry was pulling that moratorium for themselves, at the global level, there began to be a rising call. How do we better align investments? How do we increase the amount of investment? How do we make sure that these digital health programs are going to be successful? And so USAID, in partnership with the Gates Foundation and other donors, pulled together about 40 partners in digital health, and together we've created the Digital Square Partnership, and they asked PATH to lead that partnership and to really bring together and put out a rallying call for better, more aligned, more coordinated investment to overcome those challenges.
It's a great point on pilotitis, and just a reminder for those both joining us in person and online, speaking of tweetable moments, #prescription4progress is a way we can kind of keep the conversation going online. I really love the point on pilots being one of the biggest problems the sector faces. And one of the reasons I'm so excited to have you all here on stage is, so we often hear terms like systems innovation or implementation science, but it's hard to conceptualize what that actually looks like. And so you hear things like pilots can never become progress without systems innovation. And I agree, but I think you are all examples of what that really means. So just digging in a little deeper, and again, I want to talk about approaches. What are the challenges you've had? How have you worked through them? And hopefully our audience can walk away learning something and doing something a little bit differently as a result. I actually might start with Dickie here, and anyone can feel free to jump in. But can you tell us a little bit about this digital health transformation partnership you recently announced with WHO? What I'd love to hear is it builds on work that you've done in Tanzania. So what did that work in Tanzania teach you about what's needed for digital health transformation?
Great, all right. So Across all of our work in different countries, we would find that we were being asked to partner with technology leaders like the head of ICT for the Ministry of Health, or perhaps the head of data doing M&E and other indicator work. And often we were finding that what was really needed in digital transformation is truly a health system transformation, doing business differently, doing health differently. And it became so clear that you needed a certain level of political will. And what was exciting about Tanzania is that there was just a tremendous leadership and a tremendous passion for digital and some real political will at the ministerial and the permanent secretary level to engage with the Gates Foundation and say, hey, we want you to invest in us to do this right. We've had this e-health strategy, right, sitting up on our shelves that we're not getting anything done. Meanwhile, 137 in the case of Tanzania, different still the pilots going on. How do we change that? How do we move that needle? And so in Tanzania, getting together with the government, understanding what they wanted to see happen, developing a digital health investment roadmap that enabled them to prioritize the strategies that they had and to cost those strategies, and then to pull together the governance structures that could get the different donors and partners aligned behind a country-led known strategy, really demonstrated what was going to be necessary to really foster the enabling environment for all of the applications and services that were being invested in. And that enabling environment includes strong leadership and governance, strong strategy and investment, strong capacity, an interoperability architecture that everything could be invested into and pulled together, a whole greater than the sum of the parts. And really an enabling policy environment. So many of these steps are skipped when we go in and want to build an app to support maternal health or HIV or whatever it might be. And we could easily imagine time if all of that was run out to the end where health workers are sitting here with 10 different phones that have been brought in by projects or 8 different apps, and none of it is actually connecting data and pulling together again into true enablement of the care. It will increase the burden on an already overburdened health workforce. And I love to talk about disruptive technology, but in these fragile health systems, we really can't afford disruption in the same way. We need to be investing into the strength, the resilience, the agility, the adaptiveness of those systems to be able to respond effectively. So all of this led to the WHO, the new resolution. WHO, like many of the in our space, had many different aspects and fragments of investment into digital and many separate leaders who weren't well coordinated and aligned and really hadn't been called to take a leadership role in digital health. And with the new World Health Assembly resolution just this past May, they were called by all their constituent countries, unanimously approved, some 37 countries fully endorsing, to take a leadership role in not just coordinating at the country level, but coordinating at the global level to really change this. And so when WHO said, okay, well, how do we do this? They again turned to PATH and said, hey, Tedros called our CEO up and said, we really want you to come and partner with us and figure this out and bring along your entire community of partners to help solve this problem together.
So on that point about disruption, if it's okay with you all, I might bounce around on order here because Chuck, you and I have talked about this. I take the point that some of these markets, we can't afford disruption. But we've also talked about this idea of disrupt or be disrupted, right? So Chuck, can you talk about, you mentioned earlier digitally enabled community health workers.
Yeah.
You also bring an interesting perspective because you're both an entrepreneur and a funder in this space. So how do you view this question of linking technology with systems, and maybe you can get at your view on the disruption point?
Sure. So let me give you a little snapshot of of how the system that we've created for Uganda and Kenya, how it works. So one is I think I'm very resonant with one of the issues that Dickie brought up, and we're partners in crime.
Oh yeah.
I serve on one of his advisory boards, and we try to bring a really integrated approach to this, which is I think one of the challenges is people tend to go after one disease or one problem and with a very narrow solution. And not end up strengthening the overall system. So from the beginning, we brought an integrated approach. The health workers we support do everything that you can do at the community level, from childhood disease, pregnancy and newborn care, family planning, supporting vaccination tracking, and soon in the future we'll be doing non-communicable diseases. So I think the goal here is if you live in one of these communities to have one person you can go to meet your healthcare needs, and it's got to be as frictionless and easy and convenient as possible. Convenience is sort of the overarching driver if you look at disruptions in these other sectors, whether it was mobile money, or Airbnb or Uber, what have you. It's making it phenomenally easier for people to get what they need when and where they need it. Which, let's face it, healthcare systems in general has not been, right? Putting the patient at the center has not been the strong suit. And so we equip each of these health workers with a phone. But the first thing we do is that we create a system where the patients and the families and the communities know that there's someone who they can call who will come to them. This is healthcare on demand. And then the system allows that health worker to register that household, so you get a census, to do a diagnosis using a very simple sort of AI-guided tool. And then it triggers follow-ups to make sure that both at the patient side, they complete the course of treatment, and on the provider side, they follow up on the cases that need it. And then maybe most importantly for those systems, it provides a managerial backbone that allows this system to keep track of who's doing what every day, and then brings in some very basic decision rules to guide the health worker and the managers of the health worker about how to optimize their time, patient by patient, household by household. And that sounds very disruptive. It's really simple. It's just trying to do the work of healthcare systems in a more integrated and efficient way. But I do come back to your point about this challenge of disruption. Acquiring this kind of technology and putting it to use for the health system is not a strong suit of governments. They're not great at identifying the problem, having a vision for how technology can help, and then managing it. And so, I think a core theme for us, and I think in our collaboration with PATH, is how do you help your partner institutions along that journey?
Exactly.
And avoid becoming, you don't want to be the Walmart of healthcare. You want.
One of the things I've also learned in my conversations with you, and of course in this panel we're focused mainly on the link between technology and systems, but I think one of the other interesting impacts of technology in this space, and you've mentioned this, is it's drawing new funding to the space when people can have visibility into real impact in real time to say, and I know NextLeaf can probably speak to this as well, an interest from partners, from donors, and going, oh, I can see what's working based on this tech, so therefore I might be actually interested in supporting this space. I'll actually jump to Nithya. So we heard a little bit about how your data helps decision makers for things like vaccine cold storage, but specifically, how do partners help you when it comes to figuring out what markets make sense?
Yeah, actually, I'm glad you asked that. I think, and I want to speak a little bit to what we see as some of the challenges in terms of partnerships. I think the culture in our sector is one where both the funding streams and the people doing the work have created this expectation that one organization is going to do it all. And that's sort of one problem. And then I think on the other hand, the other problem is exactly as Nikki was talking about, all the kind of small one-off kind of efforts that are done. And that really plays out even in information systems, where you see all these really siloed information systems. And so if I were to just take one example, so we had the great opportunity to work with PATH in Tanzania. We've also been working with Village Reach in Mozambique with Emily here. And so I'll talk a little about actually the work in Mozambique, because I think that was early on, but really demonstrated partnerships that worked, where it really was about co-creation. And NextLeaf, we knew our role in that we were building a technology, but we wanted to make sure that technology worked for everybody, because we did want to bring value at every level. Village Reach really knew the Ministry of Health and really knew kind of the realities on the ground, and they were a fantastic partner. Finally, what I'll say though is that the ministry ended up being the most important partner, because they really kind of sat down with us very honestly and kind of laid bare what their challenges were. They really kind of every step of the way, they tried things, they failed with us and kind of learned with us, and that was really critical. And so to us, we see that partnership as being really magical. And we're starting to now see that in a much bigger scale in Tanzania, just in terms of, now we'll be close to 7,000 clinics by the end of next year that will have NextLeaf sensors in them and streaming data into a number of different information systems. And kind of the name of the game is interoperability. And that is the case both for information systems, but also for, as Chuck is talking about, kind of the types of actions and work that people are taking. And data is not going to solve everything. It's not even kind of a solution in and of itself. But what we've been really excited about is that because we've brought machine-generated data as opposed to, or at least in support of human-generated data, that there is this sort of faith in the data, and that sort of seeing the data as an indicator of truth because it is machine-generated and very clearly done in support of the needs that people have on a day-to-day basis, we found that it really has kind of helped to align everybody to work together again. One final thing I'll say is that we think a lot about private sector partnerships. Yeah. Village Reach has done great work in Mozambique around how do you kind of bring the private sector. And I think that's where our partnership with Gavi has been really exciting, because as we have learned a lot in individual countries, Gavi, which is, deploys about $1.5 billion a year to support and drive health system strengthening and vaccines across about 70 countries, they've really seen the value of this approach. And now, we have a partnership with Gavi to kind of bring our approach to 70 countries through sort of a global data platform and the technology. And Gavi's an incredible job kind of seeing and bringing in private sector partners now at scale. Because, we can talk about kind of scaling up in one country, but to truly get scale across a system, that's really something where these big entities need to move quickly and recognize innovation. And so for us, that partnership with Gavi's literally been, exponential scale from going, country to country to literally being able to reach potentially 70 countries in the next couple of years.
I'm glad you mentioned Gavi. I think we've covered at Devex some of their Silicon Valley private sector engagement strategies, and I think it's a good case study on what seems to be working as well as some of the challenges, so it's definitely worth looking at. So I want to ask Ramesh for your view on this, and really grateful to have your perspective, because I think, especially covering Silicon Valley for Devex, one of the challenges I see is much of the global health sector, international development sector more broadly, will hear about breakthrough technologies and go, oh, that doesn't apply in the markets where I work. And yes, there's a ways to go, and that's some of the work we just talked about, but right now you are working with the government of India on AI and health. And so I'd love to just hear from your perspective a little bit more about the role that even breakthrough technologies can play in accelerating global health outcomes.
Yeah, definitely. I think in my other career, I have worked on breakthrough technologies and done startups and invested my own money and so on. So that runs really well. I would say when it comes to health, especially global health, the traditional models are definitely more challenging. And I would say trying to push breakthrough too early. So I would say typically we go through 3 phases. We have the adoption, then transformation, and then disruption. And going straight for disruption is not always the best approach in what I have seen. And then when I'm working with the Indian government right now, I think it's the same phase that, yes, we have this analogy of why build more landlines when we just have mobile phones, all these cliched examples, but that's still not true. You still have to go through these phases, either geographically or in terms of, its adoption internally. And also we have this other axis, which is kind of thinking from a kind of individual physical layer to kind of a global and world scale. And I think as Nitya, you talked about, I think once you start getting this global view of what's going on, many of the technologies, and I see on your logo you have drones and satellites and really these global technologies in addition to the microscope. So I think the days of microscope are kind of limited. And we need to start thinking about how can we even take really world scale technologies to still have a microscopic and a mesoscopic view of what's going on. So in that sense, I think one of the things that keeps coming up in my work with the Indian government is this notion of a data friction. And for the longest time, I think we have made this, we have this trade-off that we have in our mind, which is either we have privacy and dignity of an individual versus whether that data is good for society. So kind of this data utility versus kind of data privacy. And the way we have been solving it is typically through regulation and legality and awareness and education and so on. But I think the world is moving on, and we have a whole new set of technologies that allows us to actually maintain both and possibly eliminate data friction over time. In fact, teaching a course at MIT in spring, exactly on the topic in AI in health and data friction, AI in health. So I think as we think forward in partnerships, one of the main frictions we have in sharing data could disappear. And so just to have some buzzwords, for cocktail hours, it's differential privacy or homomorphic encryption or federated learning, or what we are doing at MIT called split learning. I think a lot of these things will really change the way we think about partnerships.
That's really helpful. Chuck had something he whispered. For those who didn't catch it.
Is it possible we're 20 minutes in? We haven't said blockchain yet?
Blockchain.
And blockchain too.
Sorry.
So we only have a couple minutes left. For those of you who want to chime in, no pressure if you've said what you want to say. But as I mentioned, the goal of this event is not only to highlight effective partnerships for health system strengthening, but encourage more partnerships. So I hope people leave this session inspired to do something differently, maybe inspired to partner with someone you've met today. So any final thoughts or calls to action?
A quick one, which is, you talked about the private sector. I think one thing that we're going to see is the private sector is going to play an even bigger role in health delivery than we've seen in the past, because technology is bringing down the cost of delivery, and private sector, there's billions of being invested in this space, and whether you're an NGO or a government or a funder, there are big opportunities in front of you, and there's also big challenges. Governments have to figure out how to regulate these new business models, two things that we're trying to do at Living Goods: we're making our technology completely open source to partners and governments. And the other role I wear, is I'm a funder through the Goldsmith Foundation, and we're sort of looking at proposals now to provide funding for technology strategy and to fund hardware to help these institutions find their path and to build the capacity they need to find it.
Thanks for that, Chuck.
If I can add to that, I think after spending quite a bit of time in Silicon Valley at Facebook and health, and also my own entrepreneurial activities, I think we have to be very careful about kind of copy pasting Silicon Valley models for global health. And I know I'm saying something that most of you probably agree with, but I'm going to say something more a little bit stronger, which is when it comes to global health and when it comes to building partnerships, can promoting entrepreneurship actually become toxic for those environments? Okay? And do we need a completely new hybrid models that believe in cooperation, then followed by competition, as opposed to what we do here?
I think that's a great point, because I have to say these are the best case scenarios of entrepreneurial efforts that plug into systems, but not all do. Okay, I'll let you two jump in if you want to.
Well, just along I think what Chuck was saying, one of the roles that we've seen in terms of getting to more aligned partnerships between private sector and governments is thinking about how data can be used to manage the performance. So when you look at private sector, private sector is trying to mitigate risk while maximizing returns, if I were to try to boil down simply. And what we found is that governments don't always understand that perspective. And we've been able to kind of help certain ministries think about, when you bring better data, the ministry can help the private sector both mitigate their own risk, but also from the ministry's perspective, they can use the data to actually manage the performance of the private sector so that everybody knows they're kind of delivering to a common outcome. And so, but at the same time, I think we lack sort of good examples of seeing this work. And so one of the things we're really excited about is finding partnerships where people really want to both support ministries and kind of thinking through this new way of working with private sector. So that's, I think, what I'll just put out there. If anybody's interested in that, please do come talk with us.
We're a little over time, so Dickie, can it fit in a tweet?
All right, I'm going to fit in a tweet. Honestly, private sector challenges are due to market failures. We need to come together. We need to be interoperable with each other. We need to co-create the solutions, and we need to help overcome these market failures to create a rising tide that lifts all ships and really see this transformation come to pass.
Strongly agree.
You're here?
With that, I will just say, please join me in thanking our panelists.
Well done.
Hi, I'm Brittany Hume-Charm, and I'd like to introduce you to Zipline. Hold on. Maybe. Okay. Oh. So Zipline is an automated logistics company that designs, manufactures, and operates drones as a service to deliver life-saving products to those who need them, wherever they are. In early 2016, Zipline partnered with the government of Rwanda to establish the world's first national-scale drone delivery network. We established our first distribution center about 45 minutes outside of Kigali at the Z on this map. And from that point, we could reach about 2/3 of the country, including 21 transfusing facilities that the government asked us to prioritize for blood delivery service. The government chose blood delivery because it was one of the most complex and yet critical parts of their medical supply chain, and they needed help. So there's a lot of our system that sometimes you just have to see to believe. So I'm going to let my colleague Abdul and our customers in Rwanda explain a little bit about how our distribution center works and what the benefits are for the government of Rwanda.
Into different teams. We have the flight ops who care about pre-flighting planes, packing, loading the packages, and make sure that plane can fly. And then we have health ops. You can include more of the people with the knowledge of the blood product.
We make order to Zipline by using SMS or by using WhatsApp.
The package is handed to flight ops. You scan the package, and that's when we put the vehicle on the launcher. The vehicle will fly autonomously up to the hospital.
Iyo nabona ayo maraso nari gushobora gupfa. Igihe kuva basaba amaraso n'igihe yatugereyeho nta minota 5 irimo.
Iyo nabona ayo maraso kumva nawe naritabye Imana ko ariyo yagize umuntu.
We can avoid expiries, we can avoid stock out because the supply chain has improved. Blood is life, it is saving life for Rwandans.
So at Zipline, we focus on 2 main use cases. The first is routine resupply. This is about making sure that the products that health facilities use all the time and need to have on hand on the shelves are actually there and aren't expiring. So in this way, health facilities can signal to Zipline when they've reached a critical stock level and receive more product immediately. This actually helps them to realize that they don't have to hold more stock there. They can just ask for more when they need that. And so what we see is you can hold less inventory and there's less risk of expiry and waste. Our second use case are emergency deliveries. So these are the sorts of situations where it may not actually make sense for the health system to have all of those products be scattered across the whole country. Because maybe those products are really scarce or they're hard to stock or store appropriately. So in this instance, Zipline will actually centrally store those products and make them available on demand whenever the hospitals and doctors have an individual patient who needs them. And they can summons them and receive them within 15 to 45 minutes. So the results from our initial work in Rwanda for the past 2 years, which have included thousands of deliveries 7 days a week, are pretty extraordinary. So if you look at some of these numbers, we've been able to achieve 100% stock-in of those critical everyday blood products that they're using, those adult rhesus-positive red blood cells. That's what they need on hand all the time. We have 100% stock-in of those while achieving 98% reduction in waste, which is a combination that you don't typically see. Normally, if you're trying to avoid stockouts, you would be putting extra inventory there, and there would be some waste that would be a result of that. So there's a tension there that's inherent, and we've been able to achieve both at the same time. We've also seen that about 1/3 of our deliveries are for emergencies, and that in those emergency deliveries, those hospitals are using those specialized and life-saving products far more than they were before, which is actually indicating that there was real demand there that was not being tapped into because it was actually just too difficult to receive those products previously by ground. But the real impact of this is in the form of healthy patients and happy health workers. So the majority of the blood that's delivered in Rwanda goes to support maternal and child health in the form of complicated deliveries, postpartum hemorrhaging, severe anemia due to malaria in kids. And I'm happy to report that just this past weekend, the government of Rwanda was celebrating 3 hospitals that have had 0 maternal deaths over the past 7 months. And 2 of those, yes, thank you. It's quite an achievement. It's really remarkable. This is a very hard needle to move. Yeah. Yes, there's people in this room who deserve a lot of the credit. We'll get to that on the panel. This 2 of those 3 hospitals are served by Zipline. And one of those hospital directors actually called out Zipline as being a key element in their success, because no matter what condition a mother presented in at the hospital, they were able to actually treat her appropriately and care for her. And of course, you can imagine that as a doctor and working in a faraway health facility, nothing is more frustrating than seeing a patient who is in need, knowing how to take care of them, and not having the tools at your disposal. So what we're hearing from the doctors that we serve at these hospitals is that they are actually more satisfied in their roles and feel more supported by the health system because they have this service. So these results are allowing Rwanda and other countries that we're talking to completely reimagine how health systems can be transformed. So I'm excited to announce that just last week, the government of Rwanda announced a massive expansion of the Zipline service. So we will be expanding our services to reach every hospital in the country, as well as the health centers. So we're going to be going from reaching 21 hospitals to over 400. And as part of this expansion, we're also going to be looking at what are the other products that are needed besides blood. We're going to be expanding our service to include emergency vaccines, emergency and essential medicines, and also specialty products. So as you think about this, I invite you to imagine, what could this mean for urgent care if every time you had a patient who presented to a health facility in a case of an emergency, they could receive exactly what they needed, whether that was a snake bite or a rabies, need the rabies vaccine. What would this mean for universal access to primary health care if we were able to completely eliminate stockouts in every health facility across the country? And what would this mean for specialized health care if you were able to deliver the treatment that patients need to their closest health facility rather than requiring them to travel into the capital for care? So I'll leave you with one last thought. At Zipline, we've been preparing behind the scenes to really scale up our service. And we've been doing a lot to think about, what are all of the different engineering aspects that we need to achieve in order to make this possible. One of the numbers that I'm most excited about is 4 days. And that's because this is the amount of time that it now takes us to deploy a distribution center. And that's down from 60 days 2 years ago. So 60 days down to 4 days. So as one final thought, I would like to invite you to imagine, how can emergency response be transformed around the world if we're able to bring on-demand aerial relief to communities that are affected by pandemics and humanitarian disasters within 4 days, no matter where they occur. So there's one last piece of our system that you haven't seen yet, and that's how our planes land. So I will let our ZIP and our team in Rwanda bring it home. Thank you very much. Questions later.
Hi everyone, I'm Raj Kumar, President and Editor-in-Chief of Devex. Delighted to be back with all of you in the room, those of you who are joining us from all over the world for a conversation that continues the theme around prescription for progress. How do we find the partnerships that move us forward? We had a great earlier panel where we talked about some of the challenges of how do you take tech and actually make it part of a system. And then we heard this exciting presentation, Brittany, from you about Zipline, which is pretty phenomenal progress that you've had in just a short while.
Thank you.
So what we want to talk about now in this conversation is how do we actually get from the siloed approach to global health, which we're all very familiar with, to the systems that we all want to have, the stronger systems. And I think the case of Zipline is a really good one because ultimately these conversations come down to money at some level. And how do you take something like Zipline, which is a lot like a highway system? It's a piece of infrastructure that everybody could use, and not one person wants to pay for that necessarily. So how do you get the global health community more broadly to pay for that? In the case of Rwanda, how has it worked, and how might you take that to other countries?
Absolutely. So first, thanks for having me here. And before I go any further, I just have to point out that actually our first customer is sitting right next to me. So Dr. Agnes was the Minister of Health of Rwanda when they chose to adopt Zipline. And so the applause really goes to her.
Good choice, huh?
Thank you.
You signed the deal.
Yeah, so the partnership right here, actually, in first person. Yeah, happy to talk about that. So as you mentioned, Raj, we tend to think about the Zipline service as almost being like an invisible highway system in the sky that can connect central storage facilities to all the different delivery points across the country. And as you think about who could get involved, it's really asking the question of who is also interested in riding on that highway in the sky, or in opening up healthcare access and improved quality, down to the last mile. And so, as we've been partnering in Rwanda, we were at that kind of adoption stage that we heard about before on the previous panel. And so there it was: who are the stakeholders who are interested in learning about innovation, right? Who can help to, perhaps relieve some of the capital expenditures up front, so that then our customer, in this case the Rwanda Ministry of Health, can really only pay for the operating expenses. I mean, we want to see this as a commercial service. It is a commercial service, and in order for us as a private Silicon Valley startup to continue existing, it has to remain a commercial service.
So in this case, the government of Rwanda would pay kind of a base level to have the infrastructure, and then maybe if an individual program needed access to it, they would pay almost like you pay a toll on a highway.
So it's almost, in the instance of Rwanda, it's actually almost the reverse, which is that the government of Rwanda was paying for certain operating expenses. So they would be paying a service fee, based on the usage of the system. And we were able to have partners like Gavi and the UPS Foundation come in who were interested in learning about what this could mean, what a drone delivery service could mean in the case of Gavi, for example, down the road for vaccines. And as we go to other markets, what we're really thinking about is that broader adoption, transformation, disruption curve that we were hearing about. And there it's looking at, if you have a much larger capacity at a distribution center, who else could you sell some of that volume to? Who else might be interested in this? And so there it's really looking at who are some of the private sector partners who would also be interested in distributing across a national network, particularly in healthcare, whether those are private sector like pharmaceuticals or perhaps multilateral agencies that are focused on particular disease verticals. So bringing them to the table.
Yeah, there's huge potential in Zipline and ideas like it, but it does require that the global health community and the funding infrastructure also works a bit differently. I want to get Agnes Binagwaho into the discussion. You were the Minister of Health. We heard that. You're also the Vice Chancellor at the University for Global Health Equity in Rwanda. You're somebody well known to this world, and certainly this room. You famously got together a lot of the players in the global health community along a strategy in Rwanda. Yeah. But that is not necessarily the usual case. So how did you do that, and what do you think we need to do differently as a community to get more Zipline success stories?
So first I want to say that for Zipline, we didn't wait for the global community to have an idea, because guys, you are too slow. So we just saw the opportunity of, especially for saving women, and blood, because blood is so precious, and sometimes the roads are not functioning, or even if the roads are functioning, we need 4 hours, it's too late. And when we sat and they explain what they can do, we say we have to go for that. We knew that there will be a cost, and probably Rwanda will pay the highest cost because we are not yet the mass volume of service globally. But we knew also that if we start with time, we will get so much value out of that. So the money we put in that as a country was the health sector money that served to deliver blood, and also government funds for innovation. And we start together. We discover together how to do it, because it has never been done elsewhere. And also, the lesson learned should better be thought about, for that you know that you need to put the civil aviation, because it's a flying object, not non-identified, but still flying. We need also to inform the population there's something that is going to pass, it's good, it's going to save life. Don't try that you fail attack or anything, because it doesn't go so high, people see it, it's not our aviation is passing by, it's not Qatar, it's not SM, it's not KLM, it's not, what is this? So there is a lot, and also our neighbors, because people were afraid that we go and spy. So there is a lot of preparation, and for me it is the exemplification of what a public partnership do, because they just deliver. Yeah. We didn't buy the system, we use the system, like you use the post office. It's
well,
just,
and this is a good example of, from the last discussion, pilotitis. This is not pilotitis. It's the difference when you get the government to back a new innovation or an initiative, you can get to this kind of rapid scale.
In Rwanda, we used to say we don't like pilots except in Rwanda. Pilot is really a disease, and nobody is allowed to bring a pilot idea except if they bring the scaling up and sustainable plan. Then we sit together and see how to make it happen. And it's like the interoperability of the previous panel. We do that since 2010, guys, because after having 4 providers for health management system that were not talking to each other, I think it took me 3 weeks to learn how to say interoperability. But after that, nothing passed on that was not interoperable. So everything is doable, and you can see that all those innovations that has allow the country to provide more care to more people far was always a public-private, but there is a say you forgot, community partnership. It's not only PPP, it's PPCP. And because we forgot the customers that have something to say. And if we don't study how they will like it, how they will accept it, don't even try to invest money. So it's a PPCP.
I want to get Jay into the conversation. Jay Iyer is with us, and Jay, you're the executive director of the Access to Medicine Foundation, and you're looking at how countries, how governments, kind of the gaps that might exist that relate to some of what we're talking about here. You have indices about vaccine uptake and deployment. You have indices across access to medicines. Do you see the same issue country by country when you see the gaps in the number of people who are not vaccinated or the people who don't have access to medicine? Do you kind of identify the same problem we're talking about it here, or how do you look at this?
Yeah, so I mean, I think we definitely see the same problems. Every country, every situation, every therapeutic area has challenges.
Sure.
And I think the best ideas that obviously we've been rewarding from the pharmaceutical industry are the ideas that have that thinking of sustainability, have that thinking of how can we create that long-term access need solved? How can we solve that? So I mean, a couple of examples of, I agree with you that there's a lot of pilots that have been tried out, and only some of the pilots have actually been scaled up to the level where it's making enough of a public health impact and enough of an economic impact also in the societies itself. So it's important to realize that the success factors for that are very different. Success factors could include early thinking when you're setting up a particular program, or when you're in a first relationship or activity in a particular country, into thinking about not only the financing, not only access to one company's set of products, but what does the health system need? What do hospitals, what are kind of the profiles of diseases that hospitals and communities are faced with, and how can you contribute to the whole continuum of care? You tend to see, in about 10 years now, we've been evaluating the largest 20 pharmaceutical companies, and lately we've been looking at generic medicine manufacturers' activities in a variety of different geographies. And the best ideas are those that cover that entire continuum of care, work in tandem with existing systems, or help to create like a healthy market and a healthy system itself. Some of them are working also with new technology systems like drones for access, supply chain issues and things like that. So I mean, it's that tailoring that we need to have in place, and that recognition that it's not about one company peddling their wares, it's about a company ensuring that their wares are fitting into a part of the overall system.
Yeah, you need the strategy at a high level. You need to know that, what is the government's strategy, and do you fit into that continuum of care? But then also the infrastructure, right? So many of these pilots, and in fact, when you talk to big pharmaceutical companies, they thought their job many years ago was just develop the innovative technology, the medicine, or the vaccine. But then they realized we've got to actually get this to people, and there is that big gap. Yeah. I'm just curious your take on this, because you're meeting with people in the big corporate sector and the pharma companies, as well as the people at the government level. Who sees this as their problem? You now have big pharmaceutical companies that are invested in training up health workforce, or helping to build those supply chains. Where does this problem actually exist? How can a community like this get together around it?
Yeah. When a problem becomes so diverse, where there are so many different members who are responsible for the solution, it becomes almost nobody's problem, right? And I think that's the main problem why we all take the silo approach. We know how we can contribute to a particular part of it, but we don't necessarily know how to build those kind of networks, which is why I think that the network systems are really important to develop. I think one of the things that we've seen is there are some companies who've managed to understand what the problem is. I'll give a few examples to illustrate the point, right? Novartis, I think a company that has quite a wide portfolio of products in the pipeline, has quite a bit of experience in malaria, in working on neglected tropical diseases, some key donation programs for leprosy. What they've done right now is they said every product that comes from our research and development pipeline, we're going to have a group of people who are going to sit together and ensure that they're thinking about how those products are actually going to reach the populations for 106 low middle income countries. That means thinking about where this product has to be registered, thinking of affordability, not just between countries, which is classically a tiered pricing approach, but also within countries. How do you ensure that a larger segment of populations within countries are going to be reached? How do you ensure supply? Because it's not just one company's ability to produce that's going to solve the world's demand needs. It's going to be ensuring multiple companies are able to produce, especially when there's problems or shortages or supply chain errors itself. But that's, again, a question of where do you apply those principles to? All companies have standard principles and policies, but how much of that is applied across the different portfolio is kind of the place that we tend to look at. And I think understanding where the problem is a critical example. We've rewarded companies like Novo Nordisk for really looking at the different segments of the world population affected by diabetes. How do you address the bottom of the pyramid? How do you address diabetes care for children compared to pregnant women? I think that ensuring that you're slowly, or rather very quickly, but slowly thinking of a tailored strategy for addressing the different population needs is kind of one of the key success factors. And only a few companies can do that well.
Let's talk about one of the successes, because we have Sir Richard Feacham here with us, who was the founding executive director at the Global Fund. And obviously we've had a lot of progress, I said this in the opening, on many of the kind of vertical areas that we're now saying are sort of part of the problem, that we need to go to the system-wide approach. But vertical has done a lot of good things for us too. When I interviewed Bill Gates earlier this year, in fact, I asked him this question, and he said, well, is Gavi vertical? How do we, is the frame right even? But we all know we need to get to the place where we can have many more zipline type innovations that build up an infrastructure in the health system. So how do you, who spent so many years working on this issue, how do you see the point that we're at and where we go from here?
Well, thank you, Raj, and thank you, Catherine, and it's great to be here with everybody, and good afternoon. I think a topic that we're all touching on in different ways is this whole question of the relationship between the public sector and the private sector. And perhaps a few comments on that, which were very prominent in our early design of the Global Fund. In high-income countries, such as North America and Europe, we become very familiar with a financing model for healthcare which combines public sources and private sources which work closely together. And it may be, as in the US, that the public is about 50% of total health finance, or it may be, as in Europe, that more typically the public is about 80% of health finance. But we have significant public funds and we have significant private funds. And on the provider side, we have many private providers, and we also have public sector or state providers. And we're used to a system of partnership on the finance side and partnership on the provider side, and those two sides bolted together so that public funds can flow to both private and public providers. And private funds can also flow to both public and private providers. And I think we get used to that situation, which has been built up over 100 years or more. And we forget that in low-income and middle-income countries, in most low-income and middle-income countries, Rwanda would be an exception, as it is in many things. But in most low-income and middle-income countries, the reality is utterly different from what I've just described. The public sector focuses, as represented by the Ministry of Health, receives money allocated from general taxation from the Ministry of Finance, and focuses its time on the public provider system. So you have public money coming into the Ministry of Finance with some donor money, and almost a sole focus on financing the public clinics and the public hospitals. Meanwhile, everything else that is not public is going on unregulated, anarchic, unstewarded by government, and sort of doing its own thing, sometimes on a massive scale, as in Nigeria or as in India. Massive private finance, generally out of pocket, not a good thing, and private provision, far outsizing the public system, and yet the public system is where the government's almost sole preoccupation is. Right. So, and India and Nigeria illustrate that very well, but so do many other countries. So the big challenge, and many people have referred to sort of pieces of this same big issue, the big challenge is to really work to cause this systematic blend on the finance side and on the provider side, whereby a system is created, a public-private partnership on both sides, and where the government clearly takes on its role as steward of the whole system through accreditation of providers and ensuring fair play and making sure that the most vulnerable and the most disadvantaged do get the services. So government takes on its role as the steward and the guide and the policy setter and the regulator for the entire system. And anything we can do in our work to encourage that, Chuck referred to it earlier as the sort of the roadblock in taking living goods to the next step. Yep. How do we find that marriage between what the public sector is doing and what a private not-for-profit organization is delivering on a modest scale, but could deliver on a much larger scale? How do we go that next step in size, sustainability, scalability, which does require this public-private working together, which in so many countries is either non-existent or very embryonic.
It's a great point. You know, we talk about pilots. Where do these pilots come from? They're often public-private partnerships, but at a very granular level, at the project level. Yeah. You're talking about a systems level public-private partnership led by the government. Yes. And that's tough. And in fact, the phrase was brought up in the prior panel about disrupt or be disrupted. When you think of what's happening in many of the countries you mentioned, it's more than 60% of the healthcare spend is out of pocket. Yep. And the technology is moving so quickly that those same consumers, that same private market, can start to jump ahead and say, well, we're going to purchase a technology off the shelf that can read our blood glucose level or what have you. And how do we get ahead of this curve? Because it does feel like we're a bit behind the disruption that's already happening in the global health market when you see what's possible, where the technology is today. How do we get ahead of it? Anybody have a thought to that? As you say, Rwanda is the exception, and how do we make it not the exception?
It is maybe an exception, but it's because we have followed some principles. Those principles that you are teaching in the University of Global Health Equity now, based in Rwanda. But those principles is you need to create a system, and this is the responsibility of the government. However, the government doesn't work alone. The government has to put around the table the private sector, the community, the healthcare provider, etc. All the concern. And if it takes time, it's not a problem. Because after, when we all agree, it's fly. It's go quickly. In Rwanda, you took very little time to start an innovation because of this principle. The Minister of Health is just the coordinator of the health sector, no more.
Right.
And even cannot issue or propose a law without putting everybody around the table.
That's very different than what Richard has talked about, as the traditional role might be to develop a hospital network and run those hospitals.
Yeah.
You're talking about, as we heard on the prior panel, interoperability, the government saying that's a principle.
That's the principle. This is first we have a plan. We always done well with Global Fund and Gavi because we have a plan. And the plan, we do that with all the concern. Those will provide services, but also the community will receive them, and those, etc. The regulators. We have a plan, and with this plan, we put everybody around the table and say, you can improve it, explain why, and how it will be better for the people. But if not, everybody work on this plan. So the coordination and the leadership. So it is your country, you lead in your country, and you take expertise like this one. We didn't have somebody who can do what they do, so they are welcome to bring an innovation that will accelerate the implementation of this plan. And having this approach, I think it is replicable, can be done everywhere. But we should stop saying, like in the previous panel, government doesn't understand. First of all, government is not a body. They don't have here, they don't have, so it's a branch of people, and they understand very well. I was in the meeting with many Ministers of Health during many years. They understand very well. So don't believe they don't understand, you treat them like babies. Believe they understand and don't want to act, treat them like bad people. It's very different. The approach is different. Don't believe they don't understand. They're educated like you are. They have been at school like you are. They have the degree like you have. They read newspaper like you do.
But they do face a structural problem, right? I remember meeting with the health minister in Liberia, the previous one, who said maybe 50% of the healthcare provision in the country was being done by private philanthropic NGOs.
I agree with you, but where are the health professionals of Liberia? In this country. So what is the big problem? Global health regulation. How do you want a government to educate at high cost doctors that are stolen by the Western world after? So don't cry with us, act with us.
Yep.
Regulate that. You know, when you have a football player and you stole a football player from another team, you have to pay the other team. Here, they stole our doctors and they pay nobody.
You make me, you're right. You make me think of what Ramesh said in the last panel, that we need a phase of collaboration and then competition. That if we don't have that initial collaboration, and I think that includes, thinking of the people who are in this room and following this online, that includes the big foreign aid agencies, the bilateral agencies, the MDBs, it includes the big philanthropies, that they need to get together too to support that health minister and say, we will help you to develop a plan and then just to believe in your plan and not go around your plan.
And also support the ministries when they want to keep the health professionals. Liberty of movement is a human right, I have no problem with that. But if I have spent millions of my currency to educate someone, pay back please, so that he can at least educate another one.
Yeah, Jay?
Now, I wanted to give also a perspective of another group of people who are responsible for recognizing what global health impact actually means. And I think It's a growing group. It's the investment community. The investment community who support ideas such as the many ideas that are at the table like this, to understand that if you're investing in long-term approaches to access, what does it bring you? What is the kind of results you see? Give you a few examples. So we've got a growing group of about 73 investors. Those are pension funds, large banks, who previously were invited by us to endorse the principles of access to medicine. So there's a signature. Then we asked them more questions and we invited them to do more things. We said, come and speak to the companies that we've seen trying different things out and successfully working in a particular space for sometimes 25, 30, 40 years, and start talking to them about programs that they're working on in low middle income countries. Don't only start to thinking about drug pricing in the US, but also start talking about Novartis access, start thinking about Merck for Mothers, and start talking about Roche's access principles and how that has expanded access to key medicines from just approaching 1 or 10% of a population to something like 30, 40% of the population. So I think that we need that conversation to shift to what are we truly investing in? How are these smart decisions that we make early on, how are the collaborations that we're trying to get ourselves involved in actually making a difference when it comes to increasing number of volumes of patients who have access to a particular treatment itself?
Building on that, and Raj, you set up a little bit of a dichotomy between the coordination and the competition.
Right.
And in my experience, competition is really critical. And there's lots of room for competition, and there should be, in the kind of systems we're talking about. I mean, the government, having accepted its role as steward and overseer of the whole system, on the finance side, public and private, and on the provision side, public and private, then under that umbrella of government regulation and stewardship and direction, there is lots of room for competition and lots of value in competition. So, private providers can be competing with each other and with public providers. If finance is more and more demand-side finance rather than supply-side finance, patients will vote with their feet, and they will go to your clinic rather than your clinic because your clinic is better, and your clinic better catch up and learn some lessons. So there's lots of competition.
Yeah, and I think the key is competition on what, and it ought to be on the kinds of things you were just presenting, Brittany, things like the results. And ideally, that's where the investment would come in against results.
Better service delivery to those in needs. But the most important, leaving no one out, meaning focus on the more destitute to create systems that serve those ones.
Right, and that won't happen if the government doesn't own the plan, right? Because the private sector will come in and look for where there's places to make money. Not in all cases, but in many of the local private sector, certainly, you need to have a plan that focuses on everyone. Last thoughts, we have very limited time. Brittany.
Sure. I think we've heard a lot of themes here that really resonate. One is, let the country lead. And I think that we have seen that in Rwanda and in other places. Everything has to be, the country comes out first, and then figure out how the solutions and the collaboration and competition can kind of fill in behind that to help to actually increase access. And we definitely see that there's a seat at the table for making this a conversation where it is about the long-term prospects of pharmaceutical companies and thinking about emerging markets as solutions, as places where solutions can really be fostered and expanded. But I just wanted to say on that front that there's kind of the upfront piece of innovation, and then there's the longer term piece of sustaining. And there's a place for all kinds of stakeholders there to get involved.
Thank you. A last thought.
It is we need innovation because this is what will give to all the world the capacity to provide more care to more people with more quality. But we need everybody to risk on innovation. But the objective is that innovation to be as quickly as possible obsolete. meaning banal, in the usual things we do every day. It's no longer innovation. So that means sustainability, scaling up, and service for all. We need that. And I want also to say that you can have that with the private sector and make them think and reflect. We can have government to think how to include that. But those are principles behind of implementation science. The day we recognize that, maybe people will study it, and maybe they will replicate what is so obvious.
If they want to learn it, they know where to go to school, right?
Yeah.
Go ahead.
My last thought is, there's not enough best practices out there of what works, right? And also, why does it work? I think a lot of people are used to talking about, I'm really proud about what my organization does, and I'm sure everyone here is very proud about what they end up doing. But really changing the conversation to talk about what are different parts of our work that is making a difference versus things that have failed. It's fine to talk about failure and success. And having that conversation with funders, with donors, with investors, and at the country level is really important to understand. And it's important to have those conversations early on, almost while you're thinking of your project or thinking of your product that you're almost developing. Understanding the market's really kind of critical. And I find that there's, by nature, there's a lot of, the private sector's role is more and more well recognized in the last few years. I think we've seen a lot of private sector involvement in public-private community activities also. And I think supporting that means that we need to start thinking of what are the inspiring examples that we work on, and how can we expand on the inspiring examples rather than creating yet another new example that may one day never be as inspiring.
Well, how to top all those great comments. I think message to ministers of health in low and middle income countries: come to work in the morning with the question, how can I conscript and enlist the private sector in my country to achieve public policy goals?
That is tweetable. Well, thank you. I mean, one of the reasons, as you can probably tell, we put together this incredible group for this conversation is that it does feel like we are at a tipping point, that we won't have to have this panel every time and say, well, Rwanda is the exception, Rwanda is the exception. We're able to say what happened in Rwanda we can do in many other places.
We can do that in many other places.
And the success story of Zipline can come to many other places. Mm-hmm. And the people on this stage and in the room who represent the private corporations, the large pharma, medical device companies, local, national, private sector in the health sector, the big funding organizations, whether it's a global fund or a Gavi or the big foundations or foreign aid agencies, that there is a model here. There's a sense we can actually get there.
And Raj, don't forget that public-private partnership is already everywhere. All governments apply to Global Fund. What is Global Fund? A public-private partnership. We all apply to Gavi. What is Gavi? A public-private partnership. So it's there.
Yeah.
We use it. We just forgot it.
On that note, please join me in thanking this panel. And those of you who are on the live stream, stick with us. We'll be back in a couple of hours. Thank you so much for being a part of this.